This short talk will go through some of the common stroke syndromes you will encounter, and we'll try to relate the brain anatomy to the symptoms and signs of these syndromes. So as usual, we start with a case, a 68-year-old diabetic hypertensive male patient who presents to the emergency department with left-sided weakness and dysphagia. So during this talk, we'll look at the middle cerebral artery, the anterior cerebral artery, and the posterior cerebral artery, and try to show you the blood supply, the anatomy, and the relation with the clinical syndromes. The middle cerebral artery supplies the outer aspect of the cortex of the frontal, temporal, and parietal lobes, and significantly supplies the homunculus on this surface of the brain, which includes the face, the upper limbs, and bits of the torso. It also supplies some of the medial aspects of the temporal lobe, and the deep branches supplies the internal capsule. The anterior cerebral artery, on the other hand, supplies the medial aspect of the frontal lobe and the superior medial parietal lobe. Because of this, it supplies the homunculus that codes for the lower limbs. It also supplies the anterior aspect of the corpus callosum, which is the white matter that joins the two cerebral hemispheres. And finally, the posterior cerebral artery supplies the occipital lobes, the inferomedial temporal lobes, and critically parts of the thalamus and midbrain, the choroid plexus, and the ependyma of the third and fourth ventricles. You can use this this graphic to look at the different areas of the brain which are colored in on the right hand side. So you can just scroll down and see the different parts of the brain, and in that we relate them to the blood supplies. This is really important for your exams, as you will get questions regarding CTs and MR scans of the brain and naming normal structures. So let's see what a middle cerebral artery infarct looks like. So if it's a dominant or usual, which is usually left middle cerebral artery, if it's a proximal lesion, it can pretty much take out the entire MCA supply, including the internal capsule and the basal ganglia. This will lead to contralateral hemiplegia and hemisensory loss, contralateral hemineglect and hemianopia, aphasia because Broca's area is affected, acalculia and agraphia, right-left disorientation, and finger agnosia. In a non-dominant hemisphere, we get the contralateral hemiplegia and hemisensory loss, contralateral hemineglect and hemianopia. But on this side, the syndrome is associated with apraxia and spatial disorientation. Finally, with specific branches of the MCA, you can get Lacuna infarcts, pre and post central gyri being involved, or specifically the speech areas. What about the anterior cerebral artery? Well, the anterior cerebral artery will cause contralateral weakness or infarction of, with the leg being affected more than the arm, and contralateral hemisensory loss, again with the leg being affected more than the arm. The frontal lobe has some very important neuropsychiatric functions, and therefore infarction of the frontal lobe will also cause disinhibition with preservation of speech, impaired judgment, incontinence, and gait apraxia. And finally, the posterior cerebral artery with a proximal infarct, the entire area supplied by the artery is affected, which, as we said before, would include the thalamus and parts of the internal capsule. Therefore, you get the visual cortex being affected, contralateral hemianopia, some hemiplegia because of the long tracts being affected, chorea and hemibalismus because of the basal ganglia, thalamic pain syndromes, and possibly loss of voluntary eye movements because of the involvement of cranial nerve 3. With a distal posterior communicating artery lesion, this is limited to the occipital cortex, and therefore you get mostly visual symptoms, contralateral homonymous hemianopia and visual agnosia. Finally, if we look at Lacuna infarct syndromes, you could have pure motor infarcts involving the posterior limb of the internal capsule, pure sensory infarcts involving the thalamus, sensory motor deficits if the junction between the thalamus and the internal capsule are affected, and ataxic hemiparesis if the corona radiata, anterior limb of the internal capsule, are affected. As you'll notice, these are deep branches of the main arteries, mostly the middle cerebral, but also involving the posterior cerebral artery. And finally, something called the clumsy hand syndrome, in which the corona radiata and the ventral pons is affected. So that was a very brief talk involving the stroke syndromes that you're likely to come across both in real life and in your exams. If you have any questions, you can bring them up in class. Thank you very much. We talked about the posterior, middle and anterior cerebral arteries, Lacuna infarcts, and in another talk we'll go into the brainstem infarcts. Thank you, and I'll talk to you later.